Man, that sounds like real life.
Uh,
Whoever that is, that sounds like real. I recognize that sound.
Okay, so we are recording. Welcome to the 21st Community Advisory Group meeting called by the Alameda County Public Health Department. First announcement is we have live interpretation in Spanish. And if you would like to access the meeting in Spanish, please select the globe at the bottom of your screen. If you'd like to access the meeting in English, please select the globe and select English at the bottom of the screen. I'd like to allow for that announcement to be made in Spanish, and then we'll turn on the interpretation, please.
Hola, ¿qué tal? Buenas tardes. Gracias por estar aquí en la junta del Grupo Consejero Comunitario. Para todas las personas que quieran interpretación en español, por favor, háganle un clic en la parte baja de su pantalla en el globito y seleccione, por favor, el lenguaje español. Muy amables. Gracias.
Thank you. I will start it now. So also for housekeeping, wanted to note that we have interpretation in American Sign Language as well. For those of us who are viewing by YouTube, you probably won't be able to see the speaker and the signer. So please join us by Zoom if you wanted that feature. Finally, please, to all of our speakers, speak slowly for our interpreters and try to keep yourself on mute when not speaking. Otherwise, welcome everybody. I will turn it over. Oh, and finally, we have closed captioning, which you can select at the bottom of your screen, and we thank our live captioner. So I will turn it over to tonight's MC, Dr. George Ayala, our Deputy Director in Public Health.
Good evening, everyone, and welcome. I'm really so happy to see you all here with us. I am substituting for Director Watkins Tart, who had to tend to some family matters tonight, and she asked me to step in, and I'm glad. I said gladly yes, and so I'm here to welcome you. I'm going to invite all CAG members to introduce themselves on chat, and everybody who's with us tonight to introduce themselves on the chat. And because we have a packed agenda, normally I would presence everyone by inviting folks to turn on their cameras and invite and introduce themselves that way. But tonight we're going to ask you to do that via chat. So with that, I am going to introduce our first speaker. Our first speakers, Dr. Nielsen and Dr. Ma. Donata, you want to start us off?
Sure. Good evening, everyone. So we are going to start with some county updates where we are really with regard to our COVID response operations. And then we're going to move into what's happening with our schools, and then get some perspective on county, state, and CDC guidelines and what the expectations are at the different levels. And then we'll move over to partner updates. And I think the first slide after this is for Dr. Moss.
Okay, thank you. So, whoops, county updates, where we are really, I was asked to answer the question, where are we really? And so this is a lot of information, and it's not meant to be overwhelming. I'm sorry if it is. But I just was trying to do this instead of just bullets on a single slide. I wanted to put up some pictures. So I'm going to go through this, and hopefully you'll see what I'm seeing. So first of all, our daily reported cases are down to early December levels. And not just that, but when you look at our case rates by neighborhood and by race and ethnicity, you can see that those have converged on the, not only have they declined, but they are now the same really as the county-wide average. And the same goes for test positivity, both in the county overall. I'm now in the lower left panel, in the county overall in blue, and also in our HPI-1 census tracts in yellow. They're both basically
I don't think so.
3% with a delay. Sounds like we have a few people off mute. Okay, so moving to the middle, but wait, there's more. Case rates are down to about 11.6 for the county overall. Again, this is calculated with the delay. And even case rates among unvaccinated people in yellow there are declining really close to the overall average, and the case rate among vaccinated people. So really all of the impact of the winter wave is waning. Now we don't get all the information, we don't learn about every case from laboratory reported tests. So the next panel down is wastewater. So our wastewater signal, and this is really just a north part of the county right now. We don't have signal from other parts of the county, but down through Oakland, we are at pre-surge levels. In our hospitals, hospitalizations, the next panel down, we are not quite at pre-surge levels, but it takes a little bit longer to clear people out of the hospital. It took 2 months last winter. But we are actually better even than this figure shows. Down about, I think, 92 people in the hospital today and 16 people in the intensive care unit. The last panel in the middle, that's actually mask data. There is a long-running survey, Facebook survey of mask use. It's not complete, perfect data, but it is county by county data for mask use, and I think it does a reasonable job of showing trends. So actually still here in early March, very high mask use in Alameda County. About 85% of people reported wearing masks in public in the last week, using among people who use this survey tool, much higher than California in red, and much higher than national data in purple. However, this winter, not only did we see those disparities in case rates by race and ethnicity and neighborhood, but also, sorry about the background noise here, but also we continue to see disparities in hospitalizations and deaths over in the upper right by race and ethnicity. The rates of hospitalization death are highest in our Latino and Black residents, and we've seen that pattern with each surge. And of course, our vaccination rates are also lowest in those communities as well. Next slide. And then just briefly, we're going to get back and talk more about mandates and dig in a little bit to lifting mandates and the considerations for mandates in a few slides. But to briefly summarize where we are, this is the current masking requirements for Alameda County, the same across the whole state. And at this time, to my knowledge, every local health jurisdiction, all 61 local health jurisdictions in the state are also aligned with this. Masks are strongly recommended in indoor public settings for vaccinated and unvaccinated people. Starting at the end of the day, this Friday, March 11th, masks will go from being required for everyone in school and childcare settings to being strongly recommended. Masks continue to be required in healthcare settings, long-term care facilities, correctional settings, and it's not included here, but also shelter settings. Next slide, please. I think I'm turning it over. Janata, are you going to take this slide?
Sure, I can take this slide and feel free to jump in. So this slide is actually one that we shared last time. Dr. Moss had talked about this. And I just want to spend just a very brief moment on this. We know that COVID has decreased quite a bit for now, but we know that we're anticipating it to continue to circulate So we're anticipating, I think Dr. Moss had shared some projections for what ongoing transmission might look like. So we may be looking at a summer wave and maybe a fall wave as well. And we'll be continuing to look for variants that might affect us in various ways. But really our ongoing public health effort is to continue to address and prevent COVID disparities. And as Dr. Moss just pointed out, there are still quite a few disparities, especially with regard to hospitalizations and death. We are committed to continue to support vaccination and testing, and we are working right now on access to masks for our most impacted communities. I hear a little bit of background noise. We are also continuing to work on education, outreach, and resource and care navigation for those who most need it. And of course, we'll continue our case and outbreak investigations in priority settings. And I'm going to talk a little bit more in detail about some of the activities we're doing in our COVID division in the next slide. But we are going to work on a new surveillance plan for making sure we detect disease early so that we can institute any prevention measures that are needed. And of course, as broader just restrictions are rescinded or reduced, we do want to focus on more selective care and prevention activities so that people that really need assistance will get that. And then if a variant comes up where we need to have more restrictive policies in place, then we will have to address that as that comes upon us. And then, as you know, individuals, families, and institutions will really need to manage the new normal. So as we continue, we will see what that new normal will look like. And then on the next slide, I'm going to just go through this very quickly. But really, this is just a focus of what we're working on in terms of transition activities. We are moving away from, as I mentioned, universal case investigations, and we're continuing to focus on priority groups at least through the next couple of months. And we want to make sure the ARCH stipends gets out to those individuals who need it. So we have a broad range of zip codes that we're calling right now. And then just a few things that I wanted to point out. We are going to be focusing on prevention, especially in our long-term care facilities. Once we have completed all of our investigations for current outbreaks, we want to go back to our facilities and work with them on preventing future outbreaks and making sure they have good infection control, PPE, and other processes in place. We also want to make sure that there's tools and resources for individuals to make informed decisions about masking and vaccinations and other protective measures as we move into the next phase of this pandemic. And we're really looking forward to continued coordination with all of you and our newly formed coalition partners on frequent and consistent messaging. I know that some of this is a little bit repetitive from last time we met, but I wanted to make sure you know that we're committed to ongoing support for COVID response. And then just a couple more things. We are, as treatments become more available, we do want to start thinking about how we can make treatment more available to everyone and make sure people are getting access to those treatments. And that includes supporting patient navigation and treatment. And we are planning on having a long-term COVID response unit. So as time goes on, our large COVID response will start slowly shrinking, but we are committed to having a longer COVID response unit. We will be updating our surge plan so that although we may be a little smaller, we will work with our entire public health department to be able to jump in and assist as needed if there's a surge, for example. And we are committed to continuing access to resources, especially in our priority neighborhoods. And that's my last slide.
Greg, I think it might be you.
All right, thanks. I wasn't sure if there was one other person coming on. Good evening, everybody. I'm Greg Hodge. It's great to be here with you tonight, and I get the opportunity to facilitate this next part of our conversation. One of the things that stands out from what Dr. Moss and Damata shared tonight was a sense of readiness. And if we think about the level of disparities that we saw from day one of the pandemic through Delta, through Omicron, and now, as we sort of think about, what does the next phase look like? We wanted to tee up the conversation with two of our community clinicians who have been talking about this for a while, and at least in the African American Response Circle, which is a group that we also facilitate and are part of, and have brought that conversation into the CAG. So this notion of readiness, what does it look like in terms of specifics in the Black and Brown communities and other communities that have been hit the hardest? And so I'm going to invite Dr. Noha from Roots Community Clinic and then Kim Rose to speak to that, so we can get that part of the conversation really out on the table. So Dr. Noha, if you would.
Sure. Good evening, everyone. Yeah, I think, as we seem to be moving into a realm where there's a shift towards more sort of an individual, I think, onus, as opposed to sort of broader protections like universal masking and so on. How do we intervene to prevent already some severe disparities, prevent those from worsening or widening? We know that with each surge, we're seeing wide disparities. And we know that the communities that have been the hardest hit so far are also the ones that have the lowest vaccination rates, are also the ones that may be going to school, that schools that have maybe less robust infrastructure or ventilation, may have more crowding, may themselves or families be more on public transportation, or more frontline workers, have vulnerable people at home, et cetera. And so how does lifting broad protection sort of, I think we can anticipate it will have a disparate impact on those communities that have already been hardest hit. And then I think part of sort of the plan, at least as I understand it, both from the CDC and the state, is predicated upon the notion that there's access to treatment for those who are vulnerable. We know that that is also uneven. And so we have sort of lower vaccination and booster rates, more exposure, most likely, particularly as we lift protections and in the event that we see, subsequent surges, and, some of these infrastructure pieces that are not equitable. And so how do we ensure an equitable response when it seems like many of those efforts are being sort of pulled back at the same time?
Dr. Rose, if you want to add to it, and then we'll kind of open this up, because there's a question about infrastructure and what looks equitable. To me, it sort of begs the question around preparedness and readiness that we didn't see in the earliest parts of this. And so the fundamental question is like, what do we need to do differently? And I don't know, Dr. Rose, your perspective on
it? So I agree with everything Dr. Noha has raised. I think we're going to be in trouble as we move back potentially into a surge, because we've kind of shot our credibility on sort of telling people what to do, not just by lifting a mask mandate, when things are still looking disparate for low resource settings on the Healthy Places Index, which was a criteria that we sort of brought forward, but also we didn't even follow the criteria we set out for lifting the mask mandate. So I think we're going to be in a bit of a bind in terms of telling people what to do and to listen and follow the science, because we didn't do that in this last go round and introduced some confusion. For us, as we see people respond to the idea that everything's endemic and it's all going to be fine, what we're talking about and sharing out is a very short survey. It's about 3 minutes, just getting people's attitudes toward COVID, which I feel like we should track over time. That also asks not only, do you believe the pandemic is over? That's the opening question. Is it your opinion? But then also asking, do you have easy access to tests, at-home test kits? Do you feel that you have easy access to good masks, high quality masks? And then the third question is kind of a trick, is do you have a primary care doctor? because if you don't, it's going to be really, really impossible to be eligible for Paxlovid. Even if you don't have drug-drug interactions, if you don't have a primary care doctor to get to a prescription within 5 days of symptoms, I think it's going to be extremely challenging. And I know from my cancer experience that whenever there is an innovation in medicine, what we see is disparities, gaps widening, not because outcomes get worse for communities of color, but because outcomes get better for everybody else. And so that's a different way that the gap can widen. So I think what we really could be doing right now is leveraging the work that's been done by so many community partners and coalitions on the ground, and make sure that that is the foundation of how we create our strategies. And we talked briefly in a Moja meeting last hour about this meeting, the CAG itself, and how community can start to control the agenda a bit more and bring to the forefront as the top areas of conversation, the things that community partners are seeing on the ground. And then the one last thing I want to elevate and to bring to everyone's attention is that the CDC, and Dr. Moss, I did get the name of this grant in between this meeting and the last meeting, but the CDC is going to be, has announced $3 billion, and that's billion with the B, dollars for public health infrastructure, workforce, and data systems. And so I think as this money is being planned to come down through the state and to the county public health departments, I'm hoping that this group is a place where we can be strategizing about how we get a chunk of that money, because that's a lot of money to do the things that we're talking about doing, which is having our communities be ready to address the next surge, which undoubtedly there will be one.
Yeah. Before I open it up to other folks, Nick, anybody else who wants to comment on anything else, Noha or Kim, by way of specific infrastructure recommendations, anything else? Because Kim, I know you clicked off several things. Anything else that you all can suggest in terms of what needs to be sort of community-driven infrastructure that gets us even in a better posture for what we expect to be whenever the next wave comes?
Yeah, I think, some of them I think are literal buildings, infrastructure. We talk about wastewater, we talk about ventilation, we talk about HVAC. I mean, literal, like that type of infrastructure. I think data infrastructure is another really important one. I know, Donata, in your presentation, you mentioned disparities in hospitalization. I don't know that that's been something, for example, on the dashboard. I think that there's some by age, by race, or by city, by race, other slices of data that could be useful as we start to really hone our efforts, because I think that's really where we're moving to, is wanting to fine tune our efforts of where are we going to see widening of disparities by socioeconomics, by census tract, by race, and so on. One thing I forgot to mention earlier is, that I think our 5 to 11 vaccination rates really are lagging quite behind. And so that is something else, just a flag that we really do still need these community partnerships in order to bring that up to a level where I think we can feel more comfortable about what may now transpire within our elementary schools. And also just that we still hopefully can look forward to a vaccination for under 5-year-olds. And so really just, I think as many of our, when I think about infrastructure, so it's like physical infrastructure, the data infrastructure, and then I think the meeting infrastructure, right? Dr. Rhodes kind of mentioned this meeting, but where, there were spaces that were convening around equity and an equitable response and at all levels. This is the time we need to double down on those spaces, right? This isn't the time to disband those spaces, because this is the time when the disparities begin to widen for the reasons that Dr. Rhodes put really well. And so I think that would be the other piece, is how are we communicating? How are we staying nimble? How are we ensuring that we're flooding the neighborhoods that need it with whether it's vaccine access, primary care information for linkage to care, how to get treated, how to know if you even would be eligible for treatment if you needed it, with rapid tests, with N95 masks, and with the information and education needed. And then to the extent that we do get really great about, early warning system with wastewater, how are we then alerting the neighborhoods? How are we then alerting people that, we're seeing where a surge is going to be coming? And do we have the ability to, I know this is hard to do. It's hard to roll things back. When you take away masks, are you going to be able to bring them back when cases get high? I mean, I think that that's an open question, but I think it's a very reasonable question and a legitimate question that if and when we head into our next surge, can we be nimble? Can we bring back protections that need to be brought back? And can we do it in a timely fashion? Because it is concerning to me at the level of the CDC that they're using such lagging indicators as hospital capacity. We are so fortunate and blessed here in the Bay Area that we did not face that situation of overwhelming our hospitals, and that's great. But I do not feel comfortable using that as an indicator that it's time to put in public health and preventive measures. I think we need to all be clear, I think to Dr. Rhodes' point, what are those? Are there triggers that are going to say, you know what, we need to really go from a strong recommendation back to a requirement for certain things? And can we set those? I know they're hard to set ahead of time because variants can come and surprise us, but at least a framework for addressing it, a place that we address it, data that we're relying upon to address it, and a way that we're really communicating it out in a setting like this and to all of our community partners.
So, well, thank you for that. And so what we're hearing is there are elements of this infrastructure, physical, sort of brick and mortar. I think it goes, Wendy, to maybe your question about long-term response unit or response unit for long-term COVID. The sort of data infrastructure, this $3 billion with the B data systems grant from the feds might support that. The meeting space, sort of conversational infrastructure, if you will, and then communications. Like how quickly will good messages get out to the community? And so in some ways, this feels like to me, after 2.5 years or whatever it's been, a bit of a reset. And so I want to open the floor up to Nick, to anybody on the call, in terms of what else can we be doing? How do we need to get better around this sort of the elements of this infrastructure that we've identified?
I think I get plenty of time with the floor, and I just wanted to say that I really agree with a lot of what's been brought up. So eager to hear other people's input. But and just the one thing is, well, let's not. I'll leave it there.
Okay. So the floor is open. Others who want to speak to this point.
Yeah, Greg, if I can chime in. This is Galen Logan from Village Connect.
Sure, go ahead, Galen.
So I just want to first start out by applauding two powerhouses that have come through in a huge way in the Black community, and that is Dr. Noha and Dr. Rhodes. And I don't know where our community would be without those two. And I'll also say other folks and other efforts that have been made throughout the county. I also want to applaud the Public Health Department and especially their recent emphasis on seeing what has not been seen in such a long time, and that is the disparities within the Black community, especially the unincorporated area of Alameda County. And so I just want to send a big applause there. My point or my recommendation, let me put it like that, is that we not wait until the next pandemic before we begin to invest more in the communities themselves. I believe that there's folks within the community that need to bear arms, and I'm not talking about physical arms, so please don't get excited, but to bear arms in terms of information and the ability to reach out to folks who we can't reach. So when we start talking about hard to reach populations, there's people within the community who can reach those people. And so I think there's an emphasis that I think we need to place around making investments in us community-based organizations that are already on the ground and doing the work to reach out to folks, to pull those folks in training opportunities and train those folks how to be community navigators and get more into the community. Some of that is already being done, but I think more and more needs to be done. So if and when the next pandemic happens, we can enlist folks within the community as opposed to waiting for the institutions and the government to come to our help, to our aid. Hence Katrina. We don't need another Katrina. We need to be prepared for that. And so I would just say invest more in the community, preparing people within the community. Big Mama Abrams can do the job. And there's many others just like her and others in our community that can get it done. So thank you. I'm gonna stop there.
Thank you for that, Galen.
I'd like to just add on that and sort of link together and say that there are to be had. And I think of Baba Arnold Perkins, who says everyone is a piece of the puzzle and every piece is important, because there are different roles that the different organizations have been playing, but they haven't necessarily all been knitted together so that, for example, having some of the FQHCs sitting around the emoji table means that if a random person walks up to our site and has been vaccinated, they don't remember where, this was before we had care access, I could just call a few people who come to the table and find out where they got vaccinated, what they got, and be able to take care of what they needed next. And so I think that there's some efficiencies to be gained, and I think a really hard look taken at how we link these different components together, so that the investment is not just in individual organizations, but actually in a system of communication and linkage that allows us to serve as the safety net under the safety net in our communities. And I think that is what the CDC is hinting at in releasing this funding. And then the last thing I'll say is, I think that it will be good in terms of building infrastructure, that we do not build infrastructure for COVID, right? Or infrastructure for pandemic, but that we just build infrastructure that we can activate when it's needed for whatever the problem may be. Right now, the example that I can think of is turning off, CICT, case investigation, contact tracing. And I've heard there's going to be an extension, but there's always been this, like, we're going to turn it off. We're going to turn it off. We're going to turn it off. Meanwhile, if we wanted to start to look at, which Congress is also appropriating money to do in communities of color, look at long COVID and understand what symptoms people are having and actually do a prevalence study, the perfect groups to do that would be the case investigator contact tracers, because they already have people's contact information. So then we have a role for them when they're not actively dealing with CICT in a pandemic. So they can be activated and lifted up instead of turned on and off, and having people made to feel like, oh, my job's going to end because a pandemic is over, which is totally perverse incentive, right? You're wishing for the pandemic to continue so you can continue to put food on the table. How do we actually create systems of human beings doing jobs that are moldable so that they can be doing different kinds of jobs at different times instead of turning them on and off?
Any other comments on this before we get the schools piece on the table? And if this is sort of grounding us in terms of the entire conversation. Nestor, you have something, and then anybody else who wants to get in, and then we'll hear a little bit around what's happening with schools. And again, I think this framing around infrastructure applies to all of everything we're going to talk about tonight. Go ahead, Nestor.
I was just going to make a little suggestion, Greg and George, if it feels right. What do folks think it makes sense to move the piece on our agenda from, because it feels like there's a little bit of overlap with the conversation around the county, the state, the CDC, and some of what we're talking about right now. Does it make sense to move that forward and then leave the school piece for the last piece of the agenda? I'm sorry to do this, but it felt like there was some playing with the agenda that we could do that leads naturally into that next conversation. My only suggestion, I'll leave it up to you guys.
No, I think that's fine. So the intention here was to think about the sort of relationship setting with the county. So let's flip this a little bit. So Dr. Moss and George, you're up next on that.
I just wanted to check in before I get the floor again. Okay. I feel like I just want to make sure there was adequate time for people to weigh in, because I know, clearly Dr. Noha and Dr. Kim had put a lot of stuff on the table there. And
yeah. Okay. We can take a little bit longer on this. I think we're okay with time. So Reverend Arlene, you had something you wanted to add? And good evening. Buenas tardes.
Buenas tardes, senor. Yeah, thank you for calling on me. I just want to say amen to Dr. Rhodes. I appreciate the whole conversation. This is a really important topic to all of us. I just wanted to say one of the blessings I think that's come out of this whole challenge has been, I think deeper appreciation, respect, and collaboration with the CBOs. I also want to say, as one of the smaller organizations that's trying to help out here and stuff, it takes money to have infrastructure too, and we raised up, and stood up a brand new CICT team here at Eden Church, and I'm super duper proud of our team. And we've been saying, oh, we have enough to keep it going for 90 days. The money's gone, but the church is going to pay you because they said maybe there'd be a contract, and I mean, really, bilingual, trilingual, multilingual staff, and we can't give them any more hope of employment than that. Really, all this they've learned, they worked for us for 2 years. I mean, these are UC graduates mostly from our neighborhood, but I can't tell them they got any more work, So anyway, thank you.
No, thank you. And then just to put this on the table, there is a second tranche of the American Rescue Plan Fund Act dollars that is coming, 168 million, I think it is, that has not been planned for, as far as I know, from the county. And we've been having that conversation with members of the Board of Supervisors, as well as some of the agency heads. So just keeping that in mind, as well as the $3 billion that Kim referenced. Jasmine, you got something you want to add?
Thank you so much. And I also want to echo what's been said. I know there's no need to repeat it, but I really do want to emphasize it. Like, it's so important to try to design the infrastructure, whatever it's going to look like, to take advantage of the folks who have already been putting in the time to I believe it was Dr. Rhodes who said, let's find something else and how they can use information that they've gained, the experience that they've gained to better the communities in other ways. I don't think I can emphasize that enough, how important it is for future sustainability, not just for future pandemic planning, but just to make the community stronger. And that's the first one. And then the second one, I believe, is something that Dr. Noha was bringing up about being nimble with, coming back and forth with information as things change. The only thing that I would add to that is, as a CBO, we're having a little bit of trouble with trust already in the government. And it's not something new, that is not something that has never been heard, I'm sure, by all of you. But if we go back and forth on, today we're wearing masks and tomorrow we're not, we just have to be really strategic about how to do that, because we are also on the line. Our trust in the community is on the line when that happens. So yeah, I would super, super appreciate a lot of thoughtfulness in how that happens. Thank you so much.
Thank you for that, Jasmine. Gabriella, you got the floor. How you doing?
Hi, everybody. Just echoing what the last two speakers said, definitely agree with, our trust being on the line. I think it's something that our staff and community trusted messengers have already experienced throughout this period of going back and forth. And it really concerns them, if in the future people are going to want to listen to us, right? We've been an organization that has said, right, we're trusted in the community, right? But this is difficult when we're asking human behavior to change back and forth, right? Again, human behavior, right? So the other thing is also the workforce development. We've been able to, and lucky to be able to hire community members as trusted messengers. And I think to the point of, short-term contracts for these community members, it's really difficult for them, right? Because they are from the community. A lot of these community members are also just scraping by, right? So I think having these long-term pipeline of community health workers is important, and also just having more support for them, because a lot of them are new and they may not have had the chance to have a formal education, like going to college like some of us, and it's not needed for this work. I think that's what we've come to realize. It's for many of the positions that are out in the county and the city levels, they require high levels of education, which with this work, actually what I consider the most valuable is those that can build relationships with the community, build that trust, and it doesn't need a degree to do that. So I think we also have to think about that workforce development structure as well.
Great, thank you for that. Anybody else? Because this might be the moment, and Nestor, your suggestion I think is on point. His question around trust building between the community and the CDC, and in some ways the surrogate for the CDC, which is Alameda County Public Health Department. Let me turn this over then. Dr. Moss, you do get the floor again, and that's fine. George and Dr. Ayala, if y'all can sort of add to that part of the conversation, and then we'll get this in, and then we will circle back to what's going on with the schools. Don't worry.
And I just say, I hope you don't think of us as the surrogate for CDC locally. I think we try to start with what we need to do locally and use the CDC to inform our work, but certainly hopefully beyond just seen as a surrogate. And then I also just want to respond to the, oh, sorry, Greg.
No, I didn't mean it in like fully. It's just that the perception from a lot of people in the community is the government is the government. So
no, I totally understand.
Like, yeah. So
totally.
I mean, as somebody who's on the school board, I became the government at some point. And I was like, I don't think so.
Yeah. Being as a career civil servant, I understand. So the other thing I just wanted to respond to is that, a few people commented on the trust issues that I think were really, as the person who made the determination to move with the state on mask policy, I take responsibility for doing something that made the work more difficult for frontline workers in this network and others working on COVID with community members who really worked hard to promote the message of masking and really, I think, I've heard this message time and again in meetings since that policy change kind of had the rug pulled out from under them a little bit, so that's on me. We did not adequately communicate that, and I know others have brought up on this call, concerns about really that change, whether it was premature. And also, I think just the mixed messages, and I've really been trying to engage with folks to hear that feedback. I know that this has been a very difficult transition. I think that we'll in these slides we'll talk a little bit about sort of the use of mandates, but it's not going to these slides are not going to get at those fundamental issues, and I want you to know that my hope is as we move forward, we can try to rebuild a little bit of what was lost there and manage this kind of transition better in the future. That said, I think that we are in a reasonable place in terms of mask policy, but it has been certainly a challenge to get here, and I bear a lot of responsibility for that. So can we bring those slides back up? And also, I know the schools folks are already, they're eager to go. So I'm going to go quick as I can. Next slide, please. Okay, so just some of the considerations for health directives or mandates specifically, because I was asked to comment on this tonight. And so, the state has issued many COVID directives and guidelines, and sometimes it's hard to tell with the state what is a legal requirement and what is just a guideline, and we often have to ask them. The federal government rarely has issued directives for COVID. You may have heard about some high-profile vaccine mandate stuff, but generally the federal government has not done this for COVID. I think there's been really only some, CDC has really only ordered some masking in public transit, but and a few sort of related issues. But they typically set guidelines that are very influential but not binding. So most of the time when we've been talking about COVID mandates and restrictions, we are talking about mostly state or local level legal orders. And we can be more restrictive than any federal or state directives, but we can't be less restrictive. We can't say, well, we're not going to have that here. and where you see counties in California that haven't really, they've sort of made a big deal about not enforcing stuff, but they can't actually legally be less restrictive than the state. The local health officer does have a pretty broad authority to limit the spread of communicable diseases, and that is the foundation for local health orders. We can't violate the Constitution. That maybe that's obvious, but it's important. And the law does provide some guidance, but it is actually otherwise pretty broad. But we do have to use less restrictive means when possible. Mass legal restrictions applied to all county residents. This is not a typical public health. And even during the pandemic, I think it was incumbent upon us to be, has been and continues to be incumbent upon us to be judicious about this. There's no rulemaking process. There's no regulatory oversight. It's really not directly controlled by voting or anything like that. So it's a little bit unusual in terms of a legal authority. And we've used it. We've been more health protective here than the state, and the state has been, except for I think very early on, been relatively conservative with its approach, relatively, I should say, active with its use of health orders compared to a lot of places. Some key examples are shelter in place. Much of our mask policy has been more, we've had more or longer duration of mask requirements in place than a lot of places. Isolation and quarantine orders, and in our reopening cadence where we took a slow approach in the early days. And for all that, we saw the substantial impacts of COVID deaths, hospitalizations, large case numbers, and of course the disparities that we're commenting on. Sometimes we have aligned with other Bay Area counties, sometimes not. I will tell you, this comes up a lot. Each county is making the determination for what is best for themselves. We are not making decisions for county policy through agreements with other counties' health officers. However, the Bay Area in general has had a very similar approach. And the impact on the effect on our most impacted communities is always a part of these considerations. I think that, the other thing that's important is, these really depend on voluntary compliance, these mask directives, for the most part. Some people have done some enforcement of mask mandates, for example, but in a very limited way, and I think not generally. They've really, even in places where they have had enforcement, have largely relied on voluntary compliance. And I think we have to factor all of this in when we consider how we use them now and in the future. Next slide, please. So I think I've already sort of commented on this, and we've already touched on this in the discussion. But I just want people to know that our position is that COVID is not over, and we remain committed to preventing illness and death. And I acknowledge that the challenge that this communication has created for people in communities across Alameda County. I think I will, we've touched on a lot of this already. I just wanted to reiterate something that we've said in many discussions about the mask policy changes in recent weeks, but we really have a responsibility to be watchful for new surges. I think it was Noha who made the point that the CDC's new framework really isn't probably strong enough to, it's not designed to do this, and I wholeheartedly agree. We have a responsibility to be more vigilant than just what the CDC's new community level framework does for us, and that means drawing on all these sources and others that I've listed below. And I've said this before, and I'll say it again: we need to be prepared to act, including reintroducing mask mandates when needed. But I don't think we can keep them in place in anticipation of future surges. I think we have to dial them up when the risk is high and dial them back when the risk is lower. And so I know this is not adequate to address the concerns that have been brought up around this issue, but I did want to put it on the table in this group. Next slide, please. George, I don't know if you were going to jump in on this or if you want me to take this.
I think you were to start it, and I'm going to wrap it up for us.
Sure. So, I think we've had a lot of soul searching and internal discussions, and certainly in light of this, and we are. There are really several different things that inform the COVID response, and certainly mandates are a part of that. But we have invested through programs and really the vast majority of the resources that we've expended throughout the pandemic in our heavily impacted communities, and intend to continue to do so. And that means partnership with you all and other stakeholders in making sure that we are learning how to do the job better, because we can't do it without input from you all and from others who aren't represented here. And we have a lot left to do, clearly, as this has shown. This slide here focuses on just, I think, one aspect of that: communications, health promotion, and education. But certainly testing, vaccinations, navigation, and improving access to masks all have to be part of that work moving forward. COVID is not over, and neither is our work. George?
Yeah, I think to wrap it up, I would just add that, and just echoing some of the things I heard, since we're out of this surge, this is the opportunity to double down on our prevention messages and to double down on the partnerships that we hold with community. And for me, that means when we're building messages, we build them with community, that we co-author and we tailor those for specific communities. And we get better at doing that. We're not always as good as we want to be. And that we stay coordinated in our efforts to outreach, to educate. Education and prevention, health promotion, those are ongoing functions. They don't stop when surges go away or when pandemics go away. We need to figure out how to continue that body of work. And we need to just keep building multiple lines of and venues for communications, and we got to keep that open. We had a really fruitful conversation this evening about infrastructure. I need this group to know that we've been having those conversations internal to the Public Health Department and to the Healthcare Services Agency. And we have the same kinds of deliberations as we're having here and as communities are having. And one of the things that kind of surfaced in those conversations internal to the health department is that when we think about infrastructure, community is an extension of public health infrastructure, because public health responses, whether or not we're in a pandemic or a crisis, is dependent on our relationships with communities. And our responses to health issues and health needs and to disparities are best when they're community led. And that means that we have to continue to invest in those relationships with one another. And we need to stay open as public health officials to learning from community. So I'll keep it there and just kind of toss it back to Greg.
I think it's actually, Nestor, you still we're somewhere between the trust conversation and the education piece.
Yeah.
Tell you what, why don't you take this next piece if you want?
Sorry about
sure,
that.
I'll take this next piece, and no worries. I think we have maybe enough time for maybe one or two questions or comments anyway, because we do want to hear from our school folks. So I just want to open it up and see if there's any questions or comments on this piece, and see how folks are thinking about in relation to the conversation we just had previous to these few slides.
I just really wanted to appreciate, George, your last comments about, the community health, kind of public health infrastructure that I think, if we didn't know it before, I think it is clear now. We really do all have to be in this work together. And I just don't want to lose the point that I heard, Reverend Arlene and others bring up, which is that, that also means not just leveraging that infrastructure when there's a moment of crisis and then leaving folks worse off than they were when we started. We all want to come out of this stronger than we went into it, if that is at all possible. Right. And so I think that means where we've had investments, we need to look at how to continue to build upon those. And I think to Dr. Rhodes' earlier point, these are structures that can be leveraged for other things that our community is facing around community violence, around mental health issues, around overdose, and poisonings and things like that are happening right now in our community. So these are all things that can be leveraged as we move forward, and be activated and kind of, to Dr. Moss's, dialed up and dialed down. I mean, these are structures that can be used for other things when we don't need to activate for COVID. But we, I think we tend to agree we have no objective reason to think we're done with COVID either. So we have to be ready to also respond. And I just want to say that this last surge was very challenging, not only in its magnitude, but I think in terms of the state of the structure that we've built, where, I think we weren't quite, it felt like we weren't all quite ready. And it was very difficult, not only just to meet that need, but also just emotionally, folks were fatigued. So I think it's important to stay in these dialogues and not dismantle things that we've built. Because I do think it becomes that much harder to do that dialing up and down if we're not really having the conversations in between, and really honoring, I think, what has been built and what has been developed within the community in between.
I totally agree with that, and I appreciate those remarks, Dr. Noha. I do think that when we're not in crisis, when we're not responding to surges, we could use the capacities that we've built to tend to some of the upstream factors that contribute to the disparities that we see during this surge times, right? Like, there's still work to be done, and that work doesn't go away, whether or not we're responding to a crisis. So I think that's all part of the discussion that we all need to have together about what it means to build infrastructure.
And I think for the sake of time, maybe we unless there's one outstanding comment or question that I suggest that we maybe move on to the piece on schools. Does that sound good to folks? Okay, let's do that then. Thanks, y'all.
Great, happy to step in here. Hi, everyone. Good evening. My name is Salaja Suresh. I'm a senior director with Oakland Unified School District, and I'm here with a couple of colleagues as well. And I will start with our update around masking and then pass it to my colleagues if there's additional things that they want to add. But actually from the county, I know Michelle and Lisa, you guys are here. Are there things that you guys want to start with first before we get into Oakland specific?
Sure, why don't we do that if that's okay? Okay. Good evening, everybody. Michelle Smith McDonald from Alameda County Office of Education, and I will be presenting tonight with Lisa Erickson, who was our schools liaison from HCSA. So this has been a very heavy conversation to come in at the end of when it comes to schools, but I think what I want to say about this is nowhere is the weight of this felt more than it is in our schools. This has been incredibly challenging. The last Omicron surge stretched our school systems to the very limits, and in some cases broke them a little bit. And so the fatigue is tremendous. Our school leaders are exhausted. Our teachers are exhausted. Our kids are muddling through, but from a school's perspective, nobody's really okay. Everybody is trying to get to the end of the year. And this has been, the school system isn't built for this. And I've said that to a lot of people who have said, what's going on with the schools, and said the school systems simply aren't built for this. Our schools are not built to run small public health departments in addition to the day-to-day task of educating our kids, making sure they're fed, making sure they're taken care of. So the load has been tremendous. And I just want to lay that out because I want everyone to sort of understand. So let's go into the first slide. So I want to share ACOE, the work as the center of the resource base, and we'll talk some specific scenarios, but I want to just sort of lay out. We have, through the surge, we activated several areas of support for the schools. So we set up an ACOE sponsored testing site. We ran it for 7 weeks and conducted more than 850 tests of staff over 7 weeks on weekend days and into the evenings to make sure we were accommodating schedules. Substitute teaching support, you will see where we brought that in. So the statistics we had 28 members of ACOE staff go to 52 schools and substitute in 158 classes, serving about 4,000 students over the course of about a month and a half when we returned from the winter break. And then we had district staffing support, in which we enlisted the help of Robert Half Temporary Agency, and we sent temporary staff out to districts that are marked in our dark orange here to provide assistance with contact tracing, parent notification, and that, knowing that this is what our schools needed and hearing from them that they needed help. They needed bodies, they needed people in classrooms, they needed assistance. And so we have been marshaling that support. So next slide, please. So let's do a little bit of a status report on our schools and I'll talk first about staffing. So staffing shortages have eased along with the surge mostly, but our schools are still struggling for substitutes in all areas: substitute teachers, substitute clerical workers, substitute food service workers. Substitutes are still a large issue, but the staffing shortages that we saw, where we had, dozens of teachers out and school classrooms that were unable to move forward for days and weeks at a time, and things along that line, with multiple kids out right after we came back from winter break, has generally eased. PPE. So the state has delivered to the county office at-home tests and 95 masks, children's masks, additional PPE. And we have distributed millions of units since January. So I do want to share an update here that we have received some more at-home tests, and I'm going to talk about that when we get to the next slide. But the state, through an arrangement with FEMA, has created the opportunity for our schools to get tests to send home with their families before they go to their spring breaks, and then have them so that they can test when they come back to school, which may hopefully help us with some of the issues that we experienced returning from the winter break. We continue to facilitate our calls between the school leaders and Dr. Moss, Dr. Locke, Lisa Erickson, and our team with ACPHD. Last week was our 90th call. So we have put together 90 calls since March of 2020 with our school leaders. And school leaders includes our K-12 superintendents and leaders. We also have all of our charters represented, our private school leaders. We have some childcare folks that have come on there because they feel that's a source of information from them. And additionally, we have our elected school board members participating in that call. So we are doing every other week now. We were running weekly for a long time, but we are committed to those calls. And then additionally, in partnership with Lisa and ACPHD staff, we are running our COVID liaison trainings. We're now doing a monthly check-in with those folks, although we had added a check-in during the Omicron period because we had so much change in guidance. We had significant change in guidance, and people have been navigating that, and we are maintaining our guidance documents and updating those sometimes daily. And then in vaccines, we continue to promote vaccine opportunities. And I know that Jamie Harris is on this call, and her team, the team from ACPHD, continues to run stationary sites at our most impacted school districts, in addition to some mobile school sites, and those continue as well. And we continue to share out those vaccine opportunities. Okay, next slide. And so I did want to talk about test kit distribution. So as of today, the state of California dropped off 56 pallets 500,000 at-home tests to be distributed before spring break. Our rolling spring breaks start on the 28th of this month. Castro Valley is first, and they roll weekly through April 18th. We are charged with distributing to all public, charter, and private schools in the county. Additionally, the government is asking us to perhaps include the childcare sector. So I will be working with public health to work on distribution. Everything runs through the County Office of Education. Many people have heard this joke who are on our calls regularly, but we've turned into a Walgreens distribution center at the County Office of Education. Our distribution, we have a distribution team of staff who've been pulled from their regular duties, who've been working on distribution of PPE and tests full-time since January. So we have a team of folks whose sole purpose right now is to get that stuff distributed out to our schools. Keep in mind, we have no warehouse. So the 56 pallets that were delivered today are literally they're lining the hallways in the Alameda County Office of Education as we prepare to get them out. And then I think I have one more slide. And Lisa's going to hop in here and we'll talk about some of the challenges. So let's talk about masks. So we know that the masking requirement will be lifted at the end of this week for our schools. And we appreciate the thoughtfulness and the deliberation that Dr. Moss and team took to reach an alignment, to come to the alignment decision. And we know that that conversation involved meetings with our district superintendents, and we had a meeting on Thursday with our all schools group. So we've had plenty of conversation. So I just wanted to share some of our district's considerations when it comes to the masking. Districts are allowed to be more restrictive than the county, although I'd be hard pressed to find a superintendent who's excited about that ability to be more strict, because they're getting a ton of community pressure, a lot. So the couple of the issues that schools are working through are the ability to enforce a mask mandate if they have one and the county and the state have lifted the mandate. We know that many of them are consulting legal counsel around liability and whether, for example, if the state and the county don't require masks, but as a district you do, and you deny a child access to the classroom on the basis of the fact that they're wearing a mask, whether those parents would win a lawsuit if they chose to sue the school district because they're not in alignment with state and county orders. We know that there could potentially be staffing issues. We have seen some areas around the state where teachers and staff have walked off the job when masking mandates were lifted. We don't know that we anticipate that, but that is an issue that I think is weighing on the minds of our superintendents. And then, of course, masking has an impact on our isolation and quarantine rules. And so I want to bring Lisa in to talk a little bit about how we anticipate that's going to work moving forward.
Hi, everybody. Thanks, Michelle. And just want to thank ACOE once again for this partnership, because there's no way we could have done this over the last 2 years without you all. So the impacts on isolation and quarantine, as many of you know, masks are strongly recommended when you, after being exposed to, you should wear a mask for at least 10 days. And also if you come back from isolation early, you should continue to wear a mask. So that's in both of those scenarios, masks are strongly recommended. And because there won't be a mask mandate in schools, districts and schools are, kind of figuring out how to manage that. So we're, a lot of family communication, student communication around the importance of continuing to wear masks, and thinking and just in general, really emphasizing that masks are still strongly recommended in schools overall. So hopefully, after they are exposed, they'll continue to wear masks. And after when they come back early from isolation, they'll also continue to wear masks. So we're partnering with our districts and ACOE to work on communication materials and really try to, help districts support that family communication around the importance of this, through the remaining of the school year. And before we move on to the OUSD update, I also just wanted to mention childcare. We don't have a slide on childcare, but we're working very closely with the emergency childcare response team, because childcare is also struggling with similar situations as schools, and they often don't get as much kind of attention or some of the networks and trainings that schools get. So we're, meeting with them, doing the childcare check-ins, and making sure that childcare also gets their, they're asking all the questions and getting some instruction and training on the guidance that's coming out for childcare. They also have more quarantine options available now to childcare, and the masking requirements will also be lifted in childcare. So I think that's all.
Yeah, I think that's a lot.
We could go on and on.
Okay.
Cool. Any comment? Thank you all for the detail and information on this. And thank you for all the hard work to get us through this up to this point. Comments, questions from other folks about what we've heard from our schools folks?
Hi, it's Dr. Donna. I have a question.
Go ahead, Don. How you doing?
I'm good. How are you? My question is around kids with special needs and how that's being handled in the school districts with the masking mandates.
Well, I think that it's going to vary. I think that school districts are weighing, that's part of the conversations. They have a few more days to make those determinations as school districts. Only a couple have already announced what their alignment policies are going to be. But I think that the special education students, the special needs students are still part of that equation. It's been a challenge throughout because masks are not, masks can be an impediment, particularly for students with special needs in terms of both their learning, their sensory development, their functionality. And so I don't have a uniform answer because I don't think there's a uniform solution. I think it's depending on the district. This may be something that Oakland can answer more specifically because it's what they are working on or having to deal with every day.
Yeah.
Go ahead.
Go
So
ahead,
I was just going to say that just to remind everyone that we do have a safe learning team. And so these questions come up all the time daily. And the question around special ed and masking has come up a lot. And we often, when there's very specific questions, we'll work with our clinicians to get those answers for schools. But it is, like Michelle's saying, it kind of varies by district and school and their approach to those settings. Go ahead, Salja, sorry.
Yeah, no worries. So I'm here from Oakland Unified School District. I can share a little bit of where we are on the masking issue. As we've seen at kind of every juncture over the course of the pandemic, there are a lot of just really strong feelings of like where people are on like masking and other safety measures that we've taken, and right now is no exception. We're moving forward pretty cautiously when it comes to masking, specifically with indoor masking. We're going to stay with our current policies until after spring break. We really want to see what might happen following spring break before we make any decisions to move away from the requirement to the strongly recommended language. We've started distributing at-home test kits already to our school sites in preparation for spring break. And we're keeping our testing program going, as well as our vaccine outreach and vaccine clinics as well, so that we're keeping that work going while we are keeping in mind that the masking guidance, will have to change at some point. So that's what we're planning around indoor masking. Outdoor masking as well is likely to come off obviously first before we move away from indoor masking. And we're trying to work with our labor partners as well as hear from family members about that in order to determine the date for when outdoor masking will move from required to optional. We are definitely seeing improvements as, Dr. Moss was showing sort of county numbers, both internally in our data as well, in terms of test positivity, as well as the sheer number of cases, but we're not, the lowest that we've ever seen. We're still seeing numbers that are comparable to what we were seeing in the kind of mid-fall, as well as like early December, just for cases of students and staff within Oakland Unified. So that's kind of where we are in the update around masking. It's likely to come up in the school board meeting tomorrow night as well, and we'll be sharing the same update then as well.
Cool. Thank you all. And we have time, a couple minutes for questions, comments for our folks from the education side before we hear from our Moja youth mobilizers. Anybody?
Can I just add a couple of comments to what Sal just said? I'm Mara Larson-Fleming, Director of Health and Wellness with Oakland Unified School District. And I just want to say I really appreciate the conversation, and particularly what Dr. Abolada and Dr. Rhodes shared. Like Sal just said, we're continuing to do a lot of testing. We have 10 regional testing sites open, 4 sites on any given day. We are, providing a lot of at-home tests, doing regular testing at all of our sites, partnering with the county on vaccine events, really thinking about where our students live and go to school, and what vaccination rates are by neighborhood for 5 to 11-year-olds particularly, and then also our secondary students, and where we need to locate those events so that they reach the most folks. And we are still seeing whole families getting vaccinated together. And so that's the work that we want to continue to do. And just to the point about the meeting and collaborative and communication infrastructure, just a couple of examples I want to share in ways that I think that we can continue to partner. Thinking about connecting our families to our primary care providers. We have a central family resource center. We have school-based health centers in partnership with the county and our CBOs. And, I think we can do a lot of work together to reach our families and to connect and ensure that they have those access to healthcare. That is work that we were doing before the pandemic, and work I think that we can deepen based on, where, what the infrastructure is that we've established, through the pandemic. To the point about, contact tracing and workforce development, we are thinking about pivoting our contact tracers. We actually are actively pivoting our contact tracers to work on other things like vaccine outreach. And, we're sort of thinking about them as an outreach and, clerical support, and really connecting with our families around, whatever is needed for the moment. And then, I think I'll stop there. We definitely are want to continue to partner around vaccines and testing, and particularly thinking about how we use our vaccine spaces, not just to catch students and not just to administer COVID vaccines, but also to catch students up on all of their vaccines, because we know that many are behind as we're going to be entering this next school year. So just there's a lot of opportunity to continue to partner. I just really, want to say we're here to think through those things together, and looking forward to having more of those conversations and putting some things in place.
All right, thank you. In the interest of time, let's hear from our youth, our Umoja youth mobilizers, and then we can just open up for any comments, questions at the end of all of this. So let's see, George, you introducing them, or Kim? I'm not sure who, or maybe Saja, they're just ready.
Yeah, no, I think this is their floor. So Umoja youth mobilizers, you can take it.
Hello, everyone. Hi, Gregory. How are you? So if you were in the Umoja meeting, then you may have heard what I have to say. But our animated video is finally complete and out. The title of the video is You versus COVID-19 with the hashtag #FightBackGetVaxxed. We want to give a big thank you to Kevin Epps, who has been very dedicated to making the video a success, and to all of the youth mobilizers whose ideas and creativity have brought the video to life. Susanna, who's my co-lead, I'm going to shout them out: Alma, Anaya, Darius, Kanoa, Katrina, Sabrina, Yedidia, and Yanoa. You guys have been great. I have really enjoyed working with you guys. Thank you so much for all your hard work. And last but not least, I want to give a shout out to our leaders, Temi and Dr. Kim Rhodes, for the support they've given us and for trusting us to create these types of messages. We're very excited to share with you. So I'm going to have Dr. Rhodes share the video for us. If you listen closely, you can hear that every voice on the video is one of our mobilizers. If you look in the stands, you'll see some familiar faces. So please let us know what you think.
And one last shout out to Jamie Harrison for helping to link us in with the county. And I'm sorry, I just want to check the sound on my share screen to make sure it's turned on.
Yes, thank you so much, Jamie.
Here we go.
Ladies and gentlemen, welcome to tonight's main event. In this corner, weighing in at 225 pounds, the current world heavyweight champion. He's killed more Americans this year than cancer, COVID-19. And in this corner, weighing in at 109 pounds, he seems to have a bit of a runny nose and a nasty cough. The contender, Mr. Unvaccinated. All right, folks, let's get this started. Fight.
You can run, but you can't hide. Masking got nothing on me.
Looks like COVID-19 is completely demolishing Mr. Unvaccinated. Oh, look at that uppercut. Look like Mr. Unvaccinated has been infected. COVID is really getting to him.
You sure you don't want your trainer, Mr. Unvaccinated?
Looks like Mr. Unvaccinated has been knocked out. He has fallen and he can't get up. I think it's over for him.
That was light work.
All righty, folks. We're back with the rematch everyone's been waiting for. In his corner is our reigning champion. He's got a few more hundred deaths under his belt from the last time, COVID-19. And in this corner of the ring, we have a new and improved fighter back, hoping to secure victory. We can't call him Mr. Unvaccinated after working with trainers Pfizer and Moderna. Mr. Vaccinated. Fight.
I gotta call it. COVID-19 is getting killed out there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. He's out.
This video short is brought to you by the Umoja Health Youth Mobilizers crew, sponsored by UCSF, Kaiser, Youth Uprising, Global Communication, Education and Arts, Liberation Ministries, Roots Clinic, Black Cultural Zone, and the Alameda County Public Health Department.
That's great. Applause to everybody in the Umoja team. Congratulations, a great video.
I will hope you post it on your social media channels, everybody.
All right. Cool. Any comments, questions about anything we've talked about, including that great video? Anything?
I just really want to thank all the folks that gave the education presentations, in particular, shout out to OUSD. I know that this cannot be an easy thing to do by any stretch of the imagination in terms of being more restrictive. And I know that, you know, that there's a lot of factors to grapple with. So I just wanted to give that acknowledgement and really, I think it, you know, we have seen some of the worst disparities in the city of Oakland, and some of the kind of the widest variations and disparities. And so it just, for me, is a really helpful acknowledgement that, you know, when we remove these things, they're going to affect people differently, and communities differently, and students differently. I think the couple of questions that I just am wondering if folks are thinking about or considering at all, like, will there be kind of optional masked classrooms, for example, at certain schools or campuses for families and children that feel more comfortable with those. I know that logistically sounds really difficult, but I'm just curious, also curious about whether there's been consideration to a longer winter break. I feel like that was discussed maybe a little bit with this past surge, but since we know that that is when there's a high burden of cases, just curious if that's been part of consideration as we kind of think about how we're moving forward with all of this.
I'll hop in and answer really quickly. I think I've not heard any discussion about mask specific classrooms. I think that in the secondary level with electives and various classes and things and master schedules, that would be really difficult. And then the elementary levels, kids are pretty attached to their teachers, and a switch at this point in the year, I'm not sure families would go for it. I think that there's going to be a lot of encouragement. I think that, again, masks are still strongly recommended, and there's going to be a lot of language and a lot of encouragement around, acceptance of whatever choices people are making. And for those that are choosing to wear masks or still need to wear masks because they're coming out of an isolation or quarantine situation. So I suspect that in some areas, we're still going to have significant mask uptake. I think the schools anticipate that as well, and are at least hopeful of that. And then the second question was around, oh gosh, I lost it. Please remind me what the second question.
A longer winter break.
So the issue wasn't so much this year a longer break, it was the way the break was scheduled. So we had 4 or 5 districts in the county who didn't return until the 10th, whose break was moved, so they didn't leave school until right before. So some schools got out on the 16th and came back on the 3rd. Other schools didn't leave till the 22nd and they stayed out until the 10th. The ones that stayed out until the 10th fared quite a bit better because we had the opportunity to get them the state tests, and they had the opportunity. So it wasn't so much about elongating the break, but shifting it away from that immediate return of January 2nd, you come home from your family trip, and then on the 3rd, you go back to school. So I think there's going to be a lot of conversations, and school calendars are negotiable with teachers unions. And I think there's also going to be a lot of interest on the part of the labor associations to distance the end of the break from the immediate end of that holiday so that people have that week, because again, the districts that did that were able to get tests out and just fared a little better than those that came back immediately right after the break. So I think we're going to see more of that next year.
Thank you for that. We have 3 minutes left before we close tonight's community advisory group. I think there's room for just one more comment or question. Yes, Dr. Bruce.
Yeah, I have concerns about the kids when they go back, since some of them may not be wearing masks and others will be wearing masks, and what the training has been about what to do, because there's definitely going to be clashes between children. I don't think there'll be clashes between the teachers and the children, but that's a very big concern because that can affect an entire classroom, plus it can affect that child because there's something wrong with me because I have a mask, etc. So how has the school system started to think about that, Michelle?
Actually, I'm going to kick this one to Salasha because she's a little closer to the day-to-day with the kids in the classrooms, and maybe she can offer some thoughts about how they're handling that.
Sure. Salasha.
Yeah, I mean, it is definitely a real concern. And I think that that's why, at least at the district level, we've tried to make kind of a standard requirement as opposed to just like strongly recommending certain things, because by doing that, it does put the kind of arena of conflict in the classroom or in the school, and it puts teachers and principals in the position of having to like navigate different preferences. I've seen a few other districts put out communications with the changes that are happening right now around masking of like, let's just respect other people's decisions, and it might not be the same as the decision that you're making for your child. To me, that's all part of like the social emotional learning and conflict resolution and RJ, all of the things that we've been investing in for years. And this is like another manifestation of how a conflict can show up in the classroom or in schools, and kids have to have those same tools for like how to navigate that conflict with masking. And it does feel like Right now, we're going to learn a lot from the districts that are going to be early adopters of moving to that phase of recommended masking versus required masking. That I think will set the stage for what the fall is going to look like.
Thank you very much for that. And we are at 7:00 p.m. I want to end us by, appreciating everybody here. I want to thank your co-chairs, Greg and Nestor. I want to thank the interpreters and the staff that make this meeting possible. And with that, I want to bid you a good night with appreciation. Take care, everybody.